Hi, welcome to this series Approach to Hypertension. So, first of all, the motive behind this series it is to help the medical students who are newly passed out and they are struggling to diagnose hypertension in OPD and prescribe some drug to the patient. So, I have divided this series into multiple steps in which the step one is diagnosis. So, we will look at multiple steps like how to diagnose, what laboratory investigations to be done, and how a drug should be prescribed. So, it will be easy for you. So, to start with, first of all, step one that is diagnosis. So, previously, hypertension was used to diagnose with this formula like 2 BP readings taken at least at two different occasions. But currently, it is followed. But in addition, the home BP monitoring is must. So, you should advise a patient to monitor his or her BP at home also. And the gold standard method to diagnose hypertension is 24-hour ambulatory BP monitoring. So, with this method, we should diagnose hypertension. Now, let us look at classification for diagnosis. Like at what value you should consider it is a raised BP or it is a normal BP. So, first of all, there are three classification we are seeing here. First is AHA, that is American Heart Association 2025 classification. Second is ESC, that is European Society of Cardiology classification, and third is JNC. So we will look at step by step. First of all is AHA, that is American Heart Association. It has four classes: normal, elevated, stage 1 and stage 2. So what is normal? Systolic blood pressure less than 120 and diastolic less than 80 is normal according to AHA. What is elevated? Systolic is 120 to 129 and diastolic less than 80. Stage 1 hypertension, systolic is 130 to 139 and diastolic is 80 to 89 millimeters of mercury. And the stage 2 of hypertension is more than 140 systolic and more than 90 diastolic. So AHA ACC 2025 is the most commonly followed classification of hypertension currently. And similarly, you can see the values for BP readings in ESC and JNC classification. So in India, previously JNC classification was predominantly used by all the physicians, but currently it is less commonly used than AHA ACC is in more focus. JNC 7 has defined classification of hypertension, but in JNC 8 there is no new classification. They have just changed the reading, and JNC 7 classification is continued. So it is for textbook purpose currently. So you should focus on AHA-ACC 2025 classification. So coming to step 2, it is to classify the hypertension. So broadly, it is classified as primary hypertension and secondary hypertension. So 90 to 95% of adult getting diagnosed with hypertension is primary or essential hypertension only. So we do not get any definite cause for this hypertension. And the secondary hypertension is about only 5 to 10%. So why it is secondary? Because it is secondary to some primary pathology which is mentioned here. What primary pathology? First is obstructive sleep apnea. So suppose some patient with who is overweight and also diagnosed with the metabolic syndrome is coming to you and is getting diagnosed with the hypertension also. So you should suspect causes such as obstructive sleep apnea in that patient. Medication induced or substance abuse such as cocaine, it causes hypertension. And renal parenchymal diseases like chronic kidney disease. So patients who are on dialysis for chronic kidney disease, they they are having hypertension also. Fourth is primary aldosteronism. Then the renovascular diseases such as renal artery stenosis, and then hypertensive disorder of pregnancy like preeclampsia, eclampsia, etc. So why it is important to consider these causes? So you will get to know some terminologies afterwards in this session only, that some hypertension are not getting corrected after giving all the medicines available for hypertension, and of course the modifications are followed. So for those kind of hypertension, you have to treat this underlying pathology or underlying primary disease so we can get hypertension corrected. So, coming to step 3, after getting diagnosed with hypertension, there are a few laboratory investigations which are must to do in these patients. First is to look for any target organ damage. So, what are target organs such as kidney, then your eye, that is retina, heart, etc. So, does this hypertension silently damaging your organs? So, you have to look for 12 lead ECG to look for any cardiac changes. Then you have to look for serum creatinine and EGFR. Also urine albumin to creatinine ratio to look for any nephropathy, that is damage to kidney. And you also have to look for retinopathy, that is a ophthalmological examination. You have done that. Then the above mentioned secondary causes, now you have already seen the secondary causes for hypertension. So to get this diagnosed secondary cause, you have to do specific investigation according to the cause, like serum electrolyte, sodium, potassium for any renovascular or renal parenchymal diseases, also the creatinine and EGFR, then thyroid stimulating hormone, and these investigations are necessary. So coming to recognize comorbid condition, does this hypertension is associated with fasting, there is diabetes or any hypercholesterolemia? So you have to look for that also. Why it is important? To get your ASCVD risk score, atherosclerotic cardiovascular disease risk score. So the comorbid condition associated with hypertension, that is diabetes and hyperlipidemia, helps to diagnose ASCVD risk score. Why ASCVD risk score is important? It is important to get started with the treatment. Like if you are getting diagnosed with hypertension, your risk score is low, then lifestyle modifications are sufficient. But if your risk score is high, then you have to start with the medication. And last is to assist in optimal choice of antihypertensive drug therapy. What does it mean? So you have diagnosed hypertension and you have to start the patient on particular treatment. But if the patient is suffering from any hypokalemia or hyponatremia, or patient is having high serum creatinine, then there are particular drugs which you cannot give in this patient. So the baseline creatinine and electrolytes you have to. Coming to step 4, management. So you have diagnosed the patient, then you have done the routine laboratory investigation. Now you have to manage the patient. So there are two types of management. One is non-pharmacological management, second is pharmacological management. What is non-pharmacological management? This is basically the lifestyle changes you have to follow. It includes 6 steps. First is weight loss. So if your BMI is high, then 5 to 10% of weight loss will help in reduction of BP. Following of a DASH diet. It is also known as heart healthy diet. What it includes? It includes high intake of low fat dairy, fruits, vegetables, etc. And to avoid high salt and also the fried food. Now low salt intake, less than 2.5 to 3 gram per day. Regular exercise, aerobic exercises and weight training. It is important to reduce your blood pressure. Alcohol reduction, avoid alcohol, or if it is not possible, at least reduce the dose. And high potassium rich food intake such as coconut water, etc. And then let us come to the pharmacological management. So when to start non pharmacological management and when to give direct medicine, we will look it in a further steps. So after non pharmacological management, let us look at pharmacological management, and this is the most important step you should focus on during your OPD consultations. What to do? First of all, you have diagnosed hypertension, now you have to prescribe drug. So simple steps. Step 1, initial therapy. You have to start with the two drugs. Now first of all, let us look at these abbreviations. A is AC inhibitor, B is AC inhibitor or ARPs, that is angiotensin receptor blockers. B is beta blocker, C is calcium channel blocker, D is diuretic, that is thiazide or thiazide like diuretic. MRI is mineralocorticoid receptor antagonist. Okay. So in step 1, you have to start with two drugs. It is A plus C or A plus D. Any combination according to the patient's lab report you can start. First is A plus C, that is AC inhibitor plus calcium channel blocker with adequate dose. Or you can start with AC inhibitor or ARB plus thiazide like diuretic. Anyway, to proceed on step 2, you have to monitor the BP for 4 to 6 weeks. If BP is not getting control, then you have to shift to 3 drug combination. That is ACD, AC inhibitor ARB plus calcium channel blocker plus diuretic. Prefer this in a single pill combination if available. Again, in a 4 to 6 weeks, if BP is still not getting control, shift to the 4 drug combination, which fourth drug is beta blocker. Now the problem with beta blocker is it is especially useful in coronary artery disease, post myocardial infarction or heart failure patient. What does mean? Beta blocker was previously primarily used for hypertension treatment, but currently its use is restricted in cardiac patient only. So if patient is with the coronary artery disease, then you should start with beta blocker as a fourth drug. Now if BP is still not getting control, on these four drugs, then you have to add the fifth drug. So in a newer guideline, the fifth drug to be added is MRA, which is the mineralocorticoid receptor antagonist. Example: spironolactone and eplerenone. Now let us look at some other terminology like resistant hypertension. So BP is still not getting control. What is resistant hypertension? Hypertension is not getting control in on like four drugs, one of which is a diuretic. So diuretic is must. Then we have to give the centrally acting drugs like alpha blocker. Example is doxazosine, central alpha agonist such as clonidine, and other drugs which are mentioned here. Okay, so you have to follow this stepwise approach like two drugs, three drugs, four drug, five drug, and then resistant hypertension, centrally acting drugs. So these are examples of various class of drug you can see: AC inhibitors, beta blocker, calcium channel blocker, diuretics, and MRAs. Now there are some special groups in which the hypertensive drug to be followed is different. Like this classification of 1 2 3 4 5, it is available for the patient who is not having any comorbidities and diagnosed primarily hypertension, so we can follow this. But if there are special groups such as we have discussed, the patient with the coronary artery disease or post MI, you have to prefer beta blocker along with AC inhibitors and ARBs. Now patient with heart failure with reduced ejection fraction, then AC inhibitor ARB to be used, beta blocker to be used as it is a cardiac condition. MRAs and SGLT2 inhibitors are preferred in this case of heart failure. Now, patients of chronic kidney disease, AC inhibitors and ARBs are preferred to reduce proteinuria. Patients of diabetes, same AC inhibitor, ARB, and then SGLT2 inhibitor due to like the diuresis effect. In a pregnancy, labetalol, methyl and nifedipine. AC inhibitors and ARB to be avoided in pregnancy. In older adults, thiazide diuretics and CCBs are preferred. So these are special groups. Coming to step 5, now we have learned about which drugs we can give, what lifestyle modification we can advise, etc. But when to start lifestyle modification and when to start drugs. So this simple classification is very important for that. So according to our American College of Cardiology classification, the normal BP is less than 120 by 80. So the healthy lifestyle management is recommended in every patient and reassess it after 12 months. Okay. Second is if your BP is in the elevated BP range, that is systolic BP is 120 to 129 and diastolic less than 80, then you have to follow actively this non-pharmacological therapy such as a lifestyle modification. You have to follow actively and reassess your blood pressure in 3 to 6 months. But now if your BP is in a stage 1 hypertension, then you have to calculate the ASCVD risk for that patient. What is ASCVD risk? It is a score to be calculated on the basis of comorbidities, patient's age, etc. So if that score is not at high risk, that is it is low, then again the elevated BP range management, that is the active application of non-pharmacological therapy, we can continue. But if this ASCVD score is high, that is a prior coronary artery disease or like cardiac comorbidities or stage 1 hypertension with age more than 65, or patient is having diabetes mellitus or chronic kidney disease, then this is considered as a high ASCVD risk score. So in this patient we have to start antihypertensive drug therapy in addition to the non-pharmacological therapy, and we have to reassess the patient after 1 month. And the last one is stage 2 hypertension. Irrespective of patient's condition, ASCVD risk score, in this stage 2 we have to start pharmacological therapy and assess the patient after 1 month. So this pharmacological therapy and lifestyle management, when to start, at what condition. Now as we have discussed it above, the terminology called hypertension, resistant hypertension. So what is a resistant hypertension? So systolic and diastolic BP is more than 130 by 80 on triple antihypertensive drug therapy, that is ABC or ABM, whichever you are prescribing. But important point here is preferably including a diuretic. So to diagnose resistant hypertension, patient should be on 3 or more antihypertensive drugs, and one of that drug must have diuretic. That is the criteria to diagnose resistant hypertension. And it other diagnostic criteria also includes BP less than 130 by 80 but taking more than 4 antihypertensive medicines. To diagnose this condition, we have to rule out white coat hypertension, Then treatment adherence, patient is taking his medicines regularly or not, and also accurately BP levels with accurate measurements. So we have diagnosed resistant hypertension, but we have to exclude some condition such as patient's lifestyle, OSA, that is secondary cause, medication use, and other secondary causes of hypertension. Then to management, how to manage this resistant hypertension. So we have to reaffirm the importance of adherence to lifestyle and antihypertensive medication regimen. Ensure use of a long-acting diuretic as a full dose. Add mineralocorticoid receptor agonist as a fourth medication. Add a vasodilator, that is hydralazine or minoxidil. Consider referral to the appropriate specialist to get it diagnosed with the secondary cause and treat for a primary pathology. So coming towards the two terminologies, that is hypertensive urgency and hypertensive emergency. So these patients very less likely land up into OPD, but they might come to the casualty. So what are these terminologies? First of all, definition. So hypertensive urgency is a severe BP elevation but without any target organ damage. Acute target organ damage. What is target organ damage? We have seen previously: retinopathy, nephropathy, etc. And what is emergency? It is severe BP elevation, but there is a acute target organ damage. Now, how severe? BP is raised more than 180 by 110 mmHg, and here also the same reading, but target organ damage present. Here is absent, present. Acute damage to brain, heart, kidney, eyes, aorta, and other organs in emergency. Clinical features: in urgency, patient might have some mild symptoms such as headache, dizziness, epistaxis, anxiety, etc. But in cases of emergency, patient is having severe symptoms like encephalopathy, chest pain, dyspnea, pulmonary edema, etc. Other causes you can treat here. Management: for urgency, oral short-acting BP lowering drugs on OPD basis or observation basis you can give. But for emergency, immediate BP reduction with IV antihypertensive drugs in ICU or hospital. That is, you have to admit this patient for BP to be lower. Rate of BP reduction: gradually we can reduce the BP in 24 to 48 hours in hypertensive urgency, while in emergency we have to reduce the BP rapidly, the mean arterial pressure by 20 to 25% within 1 hour, and then to 160 by 100, that is 100 and 110 mmHg over next 2 to 6 hours. So within first hour 20 to 25% MAP, that is mean arterial pressure, and in the next 2 to 6 hours we have to reduce the BP till 160 100. Now in urgency, any examples for target organ damage? There are none. And you can see in emergency there is encephalopathy, stroke, MI, LV failure, acute kidney injury, aortic dissection, retinopathy with hemorrhage, etc. So let's summarize how to diagnose hypertension. So first of all, diagnosis step 1. We have diagnosed the patient. Gold standard is 24-hour ABPM. Then we classify as a primary and secondary hypertension. Third is laboratory investigation. Basic laboratory investigation we have to do in a newly diagnosed hypertensive patient. Fourth is management. Management include two parts, that is lifestyle modification and your pharmacological therapy. And next we have seen approach, like when to give lifestyle modification and when to add drugs in addition to the lifestyle modification, like with ASCVD risk score. And then lastly we have seen two terminologies, actually three. First one is hypertensive urgency and hypertensive emergency. We have seen difference of that uh, on the basis of target organ damage. And the other terminologies we have seen, it is a resistant hypertension, which include more than or equal to three antihypertensive drugs, one of which must be diuretics. So this is it in this video of approach to hypertension. So if you have any doubt, mention it in the comments. If you like this video, if you found it useful, share with your friends.